Welcome, everyone. I know we've got a few people on the line now, but we've got some more of you who will probably be joining us as we go. But we want to go ahead and get started. I want to be respectful of everybody's time. So I want to welcome you to this webinar on patient communication. I'm here. My name is Adam McWethy. I'm the Vice President of Marketing at Spear. And I want to welcome Dr. Frank Spear.
Hi, everybody. Looking forward to the next hour with you.
So we got a lot to go through, so we're going to go ahead and get started. And, we probably won't have time for questions or anything, but, I think there's a lot of great information in there. And I think we're really going to be able to kind of show you some neat stuff that we've been learning over the last year or so. So what are we doing today? Obviously, we're talking about patient communication. So the format's going to be pretty simple, but we're going to talk a little bit in the beginning about why it is that we want to focus on this. Why is it that Spear, the organization, is so focused on how we talk to patients? We're going to show you some phrasing you can use with the patients. We're going to show you how this works in real cases. A lot of the communication that Dr. Spear's been teaching for years and years. But we're also going to show you a lot of social science research that explains really why it is that this is so effective. So we've been digging in and really trying to understand the why. And so we're really excited to share some of that with you as well. So why did we decide to do this? So the big reason is we spent the last 2 years really reimagining. I know there's a lot of members on there and know that we have a patient education platform as a part of Spear Online. And we've spent the last 2 years really thinking through how do we build something better? And how do we build something that's really going to help our clinicians be able to connect with their patients so that as their clinical expertise increases, they can communicate that need with their patients. And during the development of this, we've learned so much, and we'll be launching this in October-ish, and you'll see some stuff about it. But we want to just take a minute to kind of share with the community what are these things that we've learned, and what are some things that you can start applying right away, because we don't want to wait until this thing comes out to really share all of this with you. So look for that coming. It's going to be pretty incredible. I think it's going to be pretty life-changing for a lot of practices, but that's coming. But that's kind of the impetus for all of this, is we just really needed to share that. So first thing I want to talk about is the why behind why we started doing this. And so we did some research last year, and what we looked at was Yelp reviews of practices. So I know probably all of you out there just love Yelp so much, but and there's a lot of things out there that talk about, well, how do you do reviews and systems and how do you get them updated? But we wanted to look at, specifically in dental practices, what are the root causes of why people say good things or bad things? And we got a whole white paper on this. We can send it out to you guys. But what we found was that 63%, so we looked at 1,200 individual Yelp reviews of dental practices across the country, and we found is that 63% of negative online reviews alluded to communication issues. And 1 in 5 negative reviews specifically mentioned the doctor's communication chair side. And so it's really interesting, and that's why we really took the direction we did on this new patient engagement product is we want to be there to help those chairside communications, because that's something that you guys have 100% control over. And so we want to help you with the things that you have the most control over. And this is one of my favorite examples from it. It's 2 reviews, and the first one says, I had an appointment with the office and could not stand to return. The staff, particularly the main woman who sits at the front window, was incredibly unprofessional and always had an attitude. If you didn't just go along with everything, no questions asked, you were met with attitude. I went in for my first appointment and they made me come back a separate day for my cleaning. The next time they barely cleaned my teeth and they used this machine that sprayed water all over my clothing. So, you look at an office that, if I had to guess, and I think you'd agree with me, they were probably had a great standard of care, because they brought her back to do the cleaning with Cavitron. It's awesome. And she was real mad because she didn't understand. right? And there was something that happened in the very beginning and there wasn't a communication. Whereas I like this other one because they basically talk about a similar appointment, but the second line, she says, the dental assistant actually explained the cleaning process and what they were doing while they were doing it. So very simple process that you just explain it. And it was so revolutionary or so amazing to her to actually have somebody explain something and communicate. That's all it took to create a really loyal patient who was willing to tell the world about it. And so I think that's really interesting when you look at it. So one of the things as we started working on this, we again took a look at the research, and so there's something called the elaboration likelihood model, and it's a model that looks at how do we actually have communication with people that changes an attitude on something, which is when we're talking to people within the practice and talking to the patients that come in, we want them to value what you do. And then you want them to understand why it's important. So this is really a model that helps explain that. And so what happens is, and I'll run through this really quickly, is you decide, I want to communicate something. So the first thing that you need to look at is, are they motivated to process? So are they motivated to process what you're trying to tell them? And basically this is the idea, are they aware of what's going on with their mouth? Is it their chief complaint? Are they talking about it? Do they even know they have a problem? So if they're aware, then they are motivated to listen to you talk about it. But if they're completely unaware, it's a hard place to be. So if they're not aware, you have to make them aware. And the research talks about something called peripheral cues, but that's anything where I'm not directly talking to you, anything that I am doing to make you aware. And that can create a temporary attitude change. And then you can go in and you can start communicating. So if they're motivated and they understand, then you have to ask yourself, do they have the ability to process? Or are they overwhelmed? Are they sad? Are they on their phone all the time? Are they doing this? Because if they can't hear you and you try to communicate with them, it's not going to work. So if they are, then you can go ahead and have a conversation where you have some sort of persuasive communication where I'm trying to get you to understand what is going on and why it's important. And then one of three things can happen. Great conversation. It can change the way that they think about their mouth and dentistry and value that. And what that will do is, even if they don't agree to treatment at that moment, now that they're aware and you have communicated really effectively in a positive way, so you will change their belief structure about the dental office. And that belief structure is being created by every interaction they've had with a dental professional prior to you. So the problem is that if you have a really ineffective, clunky communication, now what it tells us is there's something called the boomerang effect. And so what that does is it cements, if they have a negative perception or they were on the fence about not sure about you or anything, now that's affected them in the way they think about you and your practice in general for a long time. So, these conversations are not just to get someone to move forward at that moment. It's about, we need to think about what is being said, because it impacts how they're going to be in the practice for the future. And if you do an okay job, it doesn't do anything one way or the other, and that's fine. You can just wait till the next appointment to talk to them again. So what we're going to talk about now is Dr. Spear is going to talk a little bit about, walk through some examples of what happens when you're in these two first stages.
And, I think when Adam talks about motivated to process or ability to process, one of the things I get asked all the time is, when you do an exam on a patient, how much to present to them when you first meet them? Do you bring them back for a second visit for a presentation? There's all those kinds of questions, and we actually want to address that, because what basically Adam is saying is, if the patient's not motivated to process the information that you want to present, you are not going to be successful. They're most likely actually going to end up with a negative experience. So we need to think about how we interact with patients that sets them up to hear what we want to say, that sets the stage for them. So I'm going to go back in time to this particular patient, and I've chosen cases that are sort of unique communication styles to share with you over this time period. So this first patient's name is Paul. And I remember very clearly, I opened my new office in Seattle on March 1st of 1995. And Paul came in, it was a Monday, Paul came in on Wednesday of that week. And Paul is a great example of a very unaware patient who got completely overwhelmed in the office. So I want to kind of share a little bit with you about his experience. So when he came to me, he was 54 years old. He has an interesting chief complaint. He was referred by the dental school. He doesn't know why. Thankfully, the dental school actually sent me a letter telling me why, but he didn't know why. He has no medical issues. He doesn't have any periodontal disease except for the premolars that are left. He is missing lateral incisors. The canines are in the lateral position. He's missing a premolar on each side, and he's going to lose the other premolars on each side because of the periodontal disease around them. This is 1995. We didn't have great sinus lift techniques then, so he doesn't have great bone for implants. And so basically his treatment plan, if he wants something not removable, is a fixed bridge from the canines back to the molars. And essentially, the dental school didn't feel comfortable having a student do it, so they sent him to me. So you can imagine, and Adam alluded a little bit to something I like to talk about a lot, is what's the patient expecting when they come in your office? What's the experience they have when they come in your office? If there's a big discrepancy between the expectation they have or the experience you provide, there's a lot of stress that's created for them. So Paul's experience for 15 years has been being a patient in a dental school, kind of like cattle being herded and, long appointments. He's helped a lot of students graduate. He's got a lot of gold in his mouth. So anyway, this was my reception area in March of 1995. And Paul walked into the front door, and Debbie, who was my receptionist, and she's still with me today. She's been with me since 1986. She was sitting at the front desk, and Paul walked in and said out loud, "I think I'm in the wrong office." And Debbie said, "Are you Paul?" And he said, "Well, yes, I am." She says, "Well, no, you're in the right office." And Paul said, "I don't think so. This looks like an office for wealthy people, like lawyers and doctors, not people like me." And you can kind of understand, if he's used to the dental school environment, what is this? This is not what I'm used to. And I would suggest to you that one of the keys to communication in your practice is to have clarity about who you are and what you want to do for your patients, and to have your team understand and be able to communicate that. And so Debbie really understands the value of what we're about. As I said, she's been with me since 1986. And so she responded to Paul by saying, "Well, Paul, we do have wealthy people as patients here. We also have school teachers, mechanics, longshoremen. We got all kinds of patients." And then she said the key thing. She told Paul who we are and what we're about as an office, why we exist. You see, Paul, what we're about is providing the finest quality dentistry possible for our patients in a comfortable environment. So if that's what you're looking for, you are in the right office, because that's in fact why our other patients come to us. And she encouraged Paul to go ahead and do the exam and let me sit down and talk with him. Now, the interesting thing about 1995 is we had no digital photography. So any patient that I needed to take photographs on always had to come back for a second visit. And Adam's going to talk to you in a minute about the importance of a second visit, what it does to the psychology of the patient in terms of how they hear you. And so Paul went through the exam, and I said, Paul, for me to really help you understand what's possible, I need to get some photographs, but that means I need to have you come back. And I never charged for the second visit, because for me, if I had a patient motivated and I needed photographs, it meant it was a fairly significant case. And that meant to me it was worth my time to bring him back for 20 minutes or whatever it was for that second consultation. And so Paul agreed. We sent the slides out to be processed. He came back in. The other thing I do with patients like Paul, because he's totally unaware, is I basically tell people, my job is to give you a tour of your mouth. If you're coming back for a second visit with me, I'm just basically going to give you a tour of your mouth of what I see. I'm not going to give you a treatment plan. We're going to talk about that in a few minutes. What I'm going to do is take you on a tour. We're going to talk about the appearance of your smile. We're going to talk about your bite. We're going to talk about the condition of your teeth and the missing teeth, and then we're going to talk about the health of your gums and bones. So it's kind of a 4-part tour. So when I said to Paul, I said, Paul, I want to start with the appearance of your teeth. He literally, we were sitting at a consult table. And as soon as I said, Paul, I want to start with the appearance of your teeth, he reached across the table and he grabbed my arm. And he said, can I stop you? And I was like thinking to myself, you already did. And he said, you're the first dentist to not treat me like a dog. And I had no idea what he meant. Well, it turns out Paul hated how his teeth looked, just hated them. And so I had touched on a really emotional issue for Paul by bringing up appearance. I didn't know that, just happened to be this emotional hot button for him. And I went on and told him what I thought could be done to improve the appearance of his teeth. Debbie presented the fees for the whole treatment plan. And in the end, Paul basically said, that's more than I make in a year. He didn't make a lot of money. And he said, I need to go home and talk to my wife. Well, bottom line was that was a Wednesday. The following Monday, Paul actually showed up at our office unappointed and told Debbie he wanted to talk to me. And I sat down with him for a minute and he says, Dr. Spear, I'm here because I want to tell you in person, I'm going to do the treatment plan. And I'm going to do the treatment plan even though, because my wife and I are very frugal, we're good savers, but I connected with the fact that you addressed my mouth, not just gave me another gold onlay. And so Paul went ahead, and this is 1995, we removed the upper bis and he did the upper restoration. I never would have dreamed he would have done it, to be honest. And the interesting thing was 2 years later, he came back and little did I know, he had asked Debbie how much it would cost to get rid of all the gold in his mouth because he hated it. So 2 years later, he came back and said, Dr. Spear, I've been saving for 2 years. And he had me remove the gold in the lower as well. And I show you Paul because for me, Paul's a revelation of what can happen with a totally unaware patient who didn't know he had high dental values, didn't have a lot of money. But when you communicate who you are, you give patients the opportunity to connect with that. When you don't communicate who you are, you're just like everybody else to them. And so I think what happened for Paul was he became very motivated to process, especially when I brought up the appearance issue.
And I think that's really important. And we're going to touch on a little bit of research later as to how people actually make those decisions. But I think the thing that's important to go into now is I think you've got a concept of, okay, they're motivated, they're aware, we make them aware, and then, can they listen? But the important part now to understand is, so what do we say? Like, what do you recommend that they say and how to talk to these patients? Because it's obviously a really important step.
Yeah, so what we want to do is we basically want to talk about the models for how you present to a patient. And if you look at it in dentistry or medicine for that matter, there's kind of 3 classic models of how we present. One would be called authoritarian, another one I'll call scarcity, and the third one would be called co-diagnostic. So just to briefly outline, authoritarian is a very classic model, centuries-old model in medicine, where basically the doctor's the expert and the patient is the subject. And you basically, the doctor says, you have it, I can fix it, $5,000. And that's literally how it's presented. And it's a really traditional model. I don't think it happens often in dentistry today, but a version of it still happens in dentistry today. And the challenge of the authoritarian model is that the clinician owns the entire treatment plan. The patient wasn't involved in any of it. The patient basically has a choice, yes or no. And because they don't own any part of the plan, what it means if something doesn't go well, means the clinician owns the plan or the problem. I think what happens most commonly in dentistry today is what I would describe as the scarcity model. And in the scarcity model, it's like the authoritarian model, except the clinician is afraid. They're afraid that the patient really doesn't want treatment. And so what happens is the clinician becomes very influenced by the patient's comments about money, about insurance. And so essentially you under treatment plan. You focus on whatever they said was their chief concern, and you tell yourself, well, over time, I'll get to know them better, and over time, I'll share more with them. But in reality, what you do is you end up with this patient that now gets this very tooth-based. Every year, you try and find a tooth that's got a problem. And the scarcity issue really, again, the clinician pretty much owns most of the treatment plan. And it's really why dentists often are anxious about case presentation, because you're presenting a plan that you created. You didn't involve the patient, you created it yourself, and now are hoping the patient says yes, but you're giving them a yes or no option. And again, the ownership lies with the clinician. The co-diagnostic process is completely different. In the co-diagnostic process, what you do is you do your exam and you report findings. And I'm going to share with you in a second how you do it. It's a very simple process. You can do it for one tooth, you can do it for a whole mouth. And so what you do is you share your findings, and what you really share is the consequences of whatever that problem is. And then you work with the patient to say, where would you like to go with this? This is kind of what ideal would be. What do you want to do? And so the patient becomes involved in owning the treatment planning process. The patient starts to understand their whole mouth. They see their whole mouth as instead of, it's not just a tooth. And so the key is really three things. In a co-diagnostic conversation, your first job is to make the patient aware they have a problem. The second job is to tell them what the consequences of having the problem are. In other words, if nothing is done, what's the most likely prognosis? And the third element is to tell them the benefits of treatment. The benefits of treatment is how the prognosis would change if you did treatment. It's not a treatment plan. What you do by going through awareness, consequences, and benefits is you identify whether the patient actually wants to do treatment or not. So co-diagnosis has been around for years. My history book tells me Bob Barkley, who was killed in a plane crash in the 70s, really was the father of co-diagnosis. And what Bob Barkley said was that a patient basically can be so conditioned by a lifetime of negative dental experiences that they lose a vision of what dental health actually looks like. In other words, if you go to dentist after dentist who only talks to you about the one tooth that has a hole in it, you never hear about what health could be like for your mouth or what your smile could look like. And so what Bob said is co-diagnosis is about creating experiences, ideally emotional experiences, that help the patient get a vision for what dental health could be and help them to ask for that. And what he said was experiences and emotion build relationships, and relationships create the environment for change. So our job, by sharing awareness, consequences, and benefits, is to create an emotional response in the patient so they have a desire for something more than just fill the holes in their teeth.
So I think it's incredible because you talked about Bob Barkley's been talking about this for how long?
50 years.
Yeah, 50 years. So what's interesting is if you look into the literature now, there's this thing called shared decision making that is really making a push into medicine. And they've been talking about it for a while, but there's a lot of interest in it now because what they're finding is if you take this approach where you take the patient's goals and you use evidence-based medicine, so you get the best clinical information that you can, and you take all these other factors into account, you can actually help the patient make a really good decision. And so with physicians, it's really about how do we reduce the number of unnecessary procedures or tests because patients are anxiety driven. And so how do you get them the best information? And there's actually, I read it yesterday in Time, there's a new study that just came out, and they studied physicians, and the average physician takes 11 seconds before their first interruption from when they ask their patient, well, what brings you here today? And so what the research was saying is that we still have a really hard time with this. And so what I think is really interesting is you've been talking about this for a little
35 years.
Yeah, a couple of minutes at least. And, now we're looking at how is this moving into, other fields. And they're saying, this is how we need to be talking to patients if we're going to get healthcare spending under control, and we're going to do what's right for the patients. And so it's the same process, but I think some of this research is pretty interesting because, you figured it out a while ago. So.
And the fascinating part of all this really is that what you're doing is the patient views you as an advocate or an ally, not somebody trying to sell them something. And so just to show you what this conversation looks like, I'm just going to take one premolar, because you can have a co-diagnostic conversation over one premolar. So the patient shows up, comes for initial exam, radiograph shows decay under the amalgam, there's a bunch of cracks on the tooth. So let's walk through, what does it look like to have, quote, a co-diagnostic conversation over a single premolar? So the first step is simple. Take an image of the premolar and show them. Show them the radiograph where the decay is, show them the crack on the premolar. In this case, it's really visible on the buccal surface. So your first job in co-diagnosis is make the patient aware that there's a problem. Now, awareness of a problem doesn't make them want to do anything. What typically motivates them is the consequences of having the problem. So the second step in co-diagnosis is to explain to them what the consequences are of having the problem. Our patient education videos, there's two different types of videos we have. One is called conditions. You could rename it consequences, and another is called procedures. What you would do in this case is you go to our conditions video and you would play them a 45-second animated video of the consequences of not treating a cracked tooth, which is fracture. In this case, I'm just showing you the photograph of a fractured tooth. But what you do for the patient is, so they understand the consequences, is play them that 45-second video. It's incredibly effective. The third step in co-diagnosis is to tell them what the benefits of treatment would be. And the benefit of treatment in this case would be we can eliminate pretty much the risk of fracture. So once they understand if they do nothing, the risk is the tooth can fracture and they may lose the tooth. The benefit of treatment, it's not a treatment plan. The benefit of treatment is if we treat your tooth, we can pretty much prevent the risk of fracture. And then finally, step 4 is this something you would have an interest in treating? You hear for years people say, well, don't present a treatment plan until the patient asks for treatment. What does that really mean? You want the patient to know why you would present treatment before you present treatment. That is the opposite of the authoritarian and the scarcity model. In the authoritarian and the scarcity model, what typically happens is you hand them a treatment plan and then you try and describe why you created the treatment plan. It's backwards. In co-diagnosis, you tell them what the problem is, you tell them the consequences, you tell them the benefits of treatment, and then you say, is this something you would like to treat? Most of them are going to ask, well, how much would it cost? Which is telling you they're interested. Okay? And so if they say yes or ask how much it would cost, then you can share what the treatment options would be. Is it a filling? Is it a crown? Is it an onlay? Is it whatever it happens to be? So that's the co-diagnostic scheme. Awareness, consequences, benefits. And in reality, when you have a more complex case, like Dwayne here, you do the same exact thing. You do awareness, consequences, and benefits. It just is a larger scale presentation. And
so I'm guessing the other benefit of this is that if you make them aware, if they bite on like a popcorn seed the next week and their tooth shatters after their hygiene appointment, they're not mad at you.
Which happens. Yeah, and then they really look at you different when you present things. Exactly. And so in these complex cases, typically we do need to bring them back for a second visit, but we do the same thing when they come back. We just simply go through the awareness, consequences, and benefits. And so this is Dwayne, and Dwayne's an interesting individual in that he came for an initial exam and he was aware. He was aware that his wife hated his appearance. And in fact, he has no problems whatsoever, except his wife can't stand his teeth anymore. So he came in saying to me, I'm fine with everything, but my wife told me I have to get my teeth fixed. So he came in with a certain awareness. My job is now to get him aware of what will it take to actually correct things. the fact that gingival levels need to be changed. He's got a ton of tooth wear. And his dentist has been telling him for 20 years about his tooth wear. So Dwayne was an aware individual. Now what you need to do is walk through this tour where you describe to him what his possibilities are and what needs to be done to actually correct the appearance issues and the tooth wear he's concerned about. And again, complex cases, what I would share with you is, he again is late 1990s case. Everything was still slide film. That means he was coming back for a second visit. When people come back for a second visit, they're in a different headspace. They listen differently than if you start talking about all this stuff at the initial exam. And so in complex or larger cases, and large might be 4 units, 6 units, whatever, if the patient's not expecting what you're about to say, and it's a significant amount of dentistry, you're probably better off bringing them back and having them in the headspace where they're ready to hear it.
So I think that's one of the things that we talked about in the book was we gave them that decision tree to help them practices figure out kind of what is it that's when do you need to have a more complex conversation? But I think the thing that's really important, and you talked about it twice, was I had to bring them back because of the film, right? But what's really interesting is if we look at, so there's Kahneman and Tversky, they did a lot of research on why humans make the errors in judgment that they do. And it's this field called behavioral economics. It's pretty fascinating, but one of the big findings is that we kind of have essentially 2 systems to make decisions. So there's system 1, which is unconscious, right? And it's based on certain rules of thumb that you set up in your mind. And you just make decisions quickly. And then this other is this system 2, where you suddenly have to sit back and you have to process things and you have to think through them logically. So, hey, you've got a cavity. Everybody knows what a cavity is. Insurance is going to cover it. It's nothing out of pocket. That's a system 1 decision. This bigger, like you're going to have to come back. We're going to have to do, that's a system 2 decision. And so what we also know is that there's been a fair amount of research about something called decision fatigue. And so this is the idea that you can actually only make so many rational decisions in a day. So that's why when you look at people who are on really restrictive diets, you tend to see failures end of week, end of day. It's why Steve Jobs wore the same thing every day, is to remove decisions. And so the problem is if you've got a patient on a Thursday and you're trying to get them into system 2 thinking, they may just not be capable of doing that. And so anytime that you bring them back for a separate appointment, even if they've made a lot of decisions, even if they're in that space to talk and discuss. And so the bringing them back, it also creates an experience they probably haven't had before, I would guess. Would you agree? Or?
No, totally. Yeah.
So
they're not used to somebody taking the time and sitting down and having a just one-on-one conversation with them about possibilities.
Yeah. And so it's not, again, you wouldn't do that with everybody,
no.
But it's about the people who you've asked those questions, they've shown you some interest. Now, if you're going to have a conversation about a bigger case, let's put them in a place where they can actually listen. So let's increase the odds that they're going to hear what's going on instead of spewing at the moment where, you've got maybe their kid got suspended that day. And so it doesn't matter how great your conversation is.
And I think your concept of the fast versus slow decision process really is important because most of your patients who if they need 1 or 2 teeth treated, those are not going to be complete. You don't need bringing people back for those. You can have those conversations with people. But when you start getting into patients that have more significant issues, there's a large benefit to bringing them back and getting them in that headspace and having the photos and having everything set.
But I would also think that getting them just to agree to that is a very system 1 decision. So they can make that decision pretty quickly, and then you can have the real conversation later.
So as I said in the beginning, I wanted to pick out cases that I thought had some significant issues to talk about communication-wise. And one of the things I hear from students a lot is as you grow as a dentist, how do you go back to patients that have been with you 2 years, 5 years, 10 years, 20 years? How do you go back to them and talk to them about stuff you've never told them? So now you've got a patient of your own, and you realize that you could do some wonderful things for them, but you've never had that conversation.
Now, would they know that because maybe they came to one of our seminars and learned something new?
Yeah, there you go.
Okay.
Yeah. So I'm gonna pick out this patient. His name is Ken. And he actually came to me in 1982. And Ken is an interesting patient in that I was an associate in 1982. And so he had been in the practice of the senior dentist for 20 years. He came to me because my job was to take care of all emergency appointments. And he, quote, in his mind, had an emergency. And so what was his emergency? He woke up that morning and there was a piece of amalgam in his mouth. And he wanted to know where it came from. So Ken obviously has a lot of really significant issues. And what Ken brings to the table is the same issue we all have when we talk to our own patients. For me, as the associate, how do I talk to Ken and share things he's never heard from the senior dentist, while at the same time making the senior dentist look good? Because in your case, what you want to do with your own patients is you want to have a conversation with your patients and have them not angry at you. You want to make it okay that you've never had this conversation before. And so it comes down to, okay, Ken comes in with the piece of amalgam that he wants to know where it came from. What do we tell him today? Do we bring him back for a separate presentation? Where do we go with this case? I mean, his awareness is so small. The only thing he knew when I talked to him is he says, well, I already know someday I've been told I'll have dentures. So that's what he thinks the future holds for him. Now, in reality, I knew he didn't need to end up with dentures. His mouth could definitely be rehabilitated, but going from somebody that wonders where the amalgam fell out to a rehabilitation, that's a big stretch in terms of communication. And so this is what most of us typically do with our treatment planning. I think this is what most of us do. This is what most dental schools teach. You write down which tooth it is, you write down what the problem is, you write down a treatment plan, you write down a sequence. And if you do this for Ken, I promise you, you will blow him out of the water. He will wonder what just hit him. And so what do you present? Is it what the insurance will cover? Is it what you think he will accept? Is it what their chief complaint is? It's not an easy thing to do. So we know his focus was, where did the amalgam come from? So we have to do that. We have to tell him where the amalgam came from. But recognize his chief complaint is not a statement about his value for dentistry. His chief complaint is actually a statement of his awareness. And his awareness is pretty limited right now. His awareness is very much, I'm going to end up with dentures someday. So sure, I'm going to tell him where the amalgam came from. Now, what I would love to do is I would love to tell him he needs to come in for a full exam, radiographs, mounted models, a complete workup. I'd love to tell him that. If I tell him that without him understanding why first, he's going to get blown out of the water again. And so what I would tell you is, in patients that are very unaware, one of the best lessons I learned from a mentor of mine named Ralph O'Connor back in the 80s is, when you have patients that are unaware of what's possible, try and create a vision for them so they could imagine what it might be like to have something different. And so what I would do with somebody like Ken, and what I did with him, is I showed him photographs of some other patients that I had treated that had severely worn teeth. And basically I said, this is what's possible today. Would you have any interest in this? And this is Dwayne, the person you saw earlier. And I treated Dwayne later than I treated Ken, but I just wanted you to see that Dwayne, the person whose wife wanted him to get treatment, he ended up doing all the treatment. And so I would show Dwayne's pictures to somebody like Ken and say, Ken, this is what's possible in dentistry today. We could do this. You don't need to end up with dentures. Is this something you would have any interest in? Now, I can promise you every patient will ask the same question. How much will it cost? They all ask that question. If they're interested. If they're not interested, they typically will just say no or not say anything. And Ken said, how much will it cost? Now, the second somebody says that, they're actually interested. That means they're motivated to process. They're willing to consider possibilities. If he wasn't, he wouldn't have said that. How do I respond to these people? I never give them a number. For 35 years, this is what I've said. I can't tell you what it will cost, but it'll be as much as a car. Every time you say it, they all say the same thing. What kind of car? And you can turn to Ken and say, you know, Ken, that would be up to you. It could be a Chevrolet. It could be a high-end Mercedes. There's a lot of different options. What I can tell you, Ken, is I can tell you how much it would cost to find out. Because I'll need to get you in for a full exam, radiographs, photographs, models, and this is what it would cost to do that. So if you're interested and you're willing to pay that much money for the models, the radiographs, the exam, et cetera, then we could fine-tune a treatment plan for you. And so what I'm really doing is I'm just saying to Ken, here's what the future could look like. I'm not going to give you a treatment plan and tell you it's X thousand dollars. I'm not going to do that. What I'm going to tell you is here's the future. If you're interested, this is how much it would cost to find out. And I'm happy to do that with you. I'm happy to get the radiographs, the photographs, do all that stuff with you. In Ken's case, he said yes. He said he was interested. Now,
so I think there's two really interesting things here. So if we go back to Kahneman, Tversky, I was talking about earlier, and if you get a chance, there's a book that summarizes most of their research called Thinking Slow and Fast. But they talk about a principle called anchoring, which is where when you set something out like that, it helps to position where they're going to be in terms of value. So the mentioning the car, now they're in a place where things are not going to shock them. Whereas if you gave them no idea, you don't know actually what would anchor them. So the next thing is there's this theory, and the original stuff was done in the late 40s, but where the brain cannot handle inconsistent thoughts and actions. And so when that patient says, how much is it? And they make the they take the action to come back and pay for records and come back for that second appointment, they've now taken an action, and that action implies a value in their oral health. And so if there was any garbage sitting back there from 2 dentists ago, or, you know, a cousin who's talking to them about something, or, you know, whatever it is, or, you know, maybe a super neat Smile Direct Club ad or something, they can't have those opposing thoughts. And so once they've taken that action, they're going to have a belief structure that believes more towards where we need a patient to be motivated to process. And so once they've moved forward into that, it changes the whole way that you can have a different conversation with them. And it's easier to just know that it's going to be easier to go into those co-discovery conversations because you know where their belief structure is going to be, or you have a better sense of where it's going to be.
Okay, so I'm gonna back up with Ken for a minute, because what I told you was what I did is I created kind of a vision for him of what's possible. I'm going to back up to the beginning of my conversation with him, because for me, talking to an existing patient is really a 4-step process, and I want you to get what the 4 steps are. They lead up to, Ken, this is what's possible today. And so in my case, I was the associate. Ken was the patient of the senior dentist. His name was Dr. Scott. He was an excellent dentist. He was my family dentist. And so the first step in talking to existing patients in your practice is you basically have to make it okay that you've never said what you're about to say. And I will tell you, my first rule, and I learned this as the associate, is always start with something positive. So in Ken's case, I said, you know, I can't believe you've been with Dr. Scott 20 years. Your gums and bone and roots are really healthy. So find something positive. I used to always say to them, you're so lucky to have Dr. Scott as your dentist, because in the 20 years you've been here, you haven't lost any teeth. And Dr. Scott was an excellent dentist. It's a little more awkward if it's your own patient to say you're so lucky to have been with me for 20 years, but Find something positive to start the conversation. Step 2, you have to help them understand that teeth wear out. And so what I say to patients all the time is, there are some parts of your mouth that are starting to show some wear and tear. And I want you to realize that just like a car wears out with age and being driven, so do teeth. So 20 years ago, when you came to this practice, your teeth were not the same as they are today. They've been slowly changing, and now those changes are adding up to a point where I see some things I think we need to discuss that we've never discussed before. Even though you've been with me 5 years or 3 years or 10, whatever it is, I want to have a conversation with you we haven't had before. And part of why we've never had it before is your mouth has been slowly changing, but it's now reached a level where I want to have that conversation. Third step, make them aware of how much dentistry has changed. And so the good news is that while you've been in our practice, dentistry has been changing dramatically in terms of materials and techniques. So as your teeth have been changing, what we can do to treat you has actually been improving dramatically. So I know we've never talked about this before, but it's because your teeth have been changing, and what I can do to help now has changed significantly. And then finally, step 4, acknowledge you, the dentist, have changed. As you've done CE and you're part of a study club, or you've been coming to take CE in workshops, you've grown, and now you can see and do things you couldn't do a few years ago. And so it's a combination of them having some positive things to start, them acknowledging that their mouth has changed over time, dentistry has changed over time, and in fact, you as a dentist have changed over time. And so let me share with you what I see happening. Now, a key, most likely for existing patients, all of this is happening at a hygiene visit. It is not a good place for that conversation. I would strongly suggest what you do is just do the first 4 steps and say, I'd love to get you back. We'll take a few photographs, and then I can sit down with you one-on-one, not interrupted, and I can share with you what it is I'm seeing. Again, you're not going to be having these conversations over 1 or 2 teeth. So these are the kinds of conversations you have with a patient who has some significant issues. And that's why, in fact, you want to have that patient back. Is it's worthwhile to have them back if they're interested in looking forward at this process. So I would strongly suggest you bring them back for a second, again, 15, 20 minutes. I personally, for an existing patient, I wouldn't charge for that, just like I don't charge for photographs. I don't want barriers to patients saying yes. If I'm doing all this, it's because that patient has some issues that are significant enough for me to take my time to do this. I don't want any barriers to them coming back and saying yes. So in Ken's case, if he's interested in getting the records and all those things, you bring him, you get the radiographs, you get the photographs, you do the models, you bring him back and talk about treatment plans. If he's not interested, basically you tell him the amalgam came out of a lower premolar and you can do a composite and you're done. Just to show you where Ken ended up, Ken, who came in because the amalgam was in his mouth, actually did everything. Again, shocking when people are presented the opportunity to say yes. If they value dentistry, it is shocking how they've come up with the way to do the dentistry. Ken is not a wealthy individual. It had a very high value to not end up with dentures. He just didn't know that was a possibility for him. Now, last patient that I want to walk you through is one that addresses what I'll call the creation of value. And I think we all fall into a trap when we have long-term patients, in that we assume because a patient's been with us a long time, they trust us. And that trust level is so high that we don't need to take the time to communicate clearly with them the way we would with a brand new patient. So I'm going to walk you through Phil. And Phil, when this photograph was taken, was 50 years old. I had been seeing him for 15 years. I treated every single posterior tooth in his mouth when he presented to me 15 years ago. Phil has a tremendous Pepsi Cola habit, and he had massive erosion on his posterior teeth. And so every single posterior tooth got treated because of the severe erosion. Now, at that time, he didn't want to do anything with his upper anterior teeth. What's really interesting is he loves getting his teeth cleaned, loves it. And so he comes in to see the hygienist every 4 months, no matter, he doesn't have any periodontal disease. He just loves it. So he comes in, he gets his teeth cleaned, and then he goes back and he drinks his Pepsi all day long. So his posterior teeth are still doing terrific, but his anterior teeth are really getting a ton of erosion. They've been restored with composite. The erosion's going on around the composite now. And our hygienist has talked to him about his anterior teeth literally for 15 years. And he's like, nah, I'm fine. At one recall, out of nowhere, he finally says to the hygienist, you know, I don't like my front teeth anymore. She comes over to me and she says, Phil's here and he wants to talk about his front teeth. Well, I was in the middle of a big procedure and I honestly didn't have a lot of time, but I had actually been on social. Phil and I had been motorcycle riding together. We'd been fly fishing together. He wasn't just a patient for 15 years. I had actually done some social things with him. And so I thought to myself, you know, Phil's a long-term patient. He trusts what we're going to do. And so I said to the hygienist, you know, at the end of the appointment, I'll just come over and I'll walk him up to Debbie and I'll have Debbie talk to him about the 6 veneers. And so I took Phil up to Debbie and Debbie walked through the need for 2 appointments, the need to send the models out to the lab for a diagnostic wax up, the need for provisionals to evaluate new tooth length, et cetera, and then the final fee for the restorations. And Phil made the appointment and everything was smooth for a week. And so this is what his teeth look like. You can see the erosions primarily on the facial. A week later, he called the office and he told Debbie he wanted to talk to me. And so I picked up the phone and Phil said, you know, I love your hygienist and I'm going to keep coming to your office for my cleanings because I love your hygienist, but I'm going to have the veneers done somewhere else. And I can tell you, I felt like somebody stabbed me in the heart. Was like, how could a patient of mine, after 15 years, and I treated all of his back teeth, and I'd done stuff socially with him, how could he leave me? And I finally said, so why? Why are you not coming back? And he said, well, you know, I work in an office where several other people have veneers and they paid a much lower fee than what you proposed to me. So I'm going to go to the dentist that did their veneers. And immediately I thought to myself, how did this happen? And in reality, what happened is Phil doesn't see the value of my veneers. Phil thinks a veneer is like a Chevrolet. You could buy the same Chevrolet at 5 different dealerships. Why not go find the cheapest one? I never propose treatment on anterior teeth where I need wax ups and provisionals and all those things without going through a value creation presentation. It only takes a few minutes. And I actually use photos of my daughter who had very small anterior teeth. And I show why a wax up's necessary to work out, you know, what tooth size and shape we might want, why a provisional is necessary to transfer that wax up to the patient's mouth so we can test drive the color of the teeth, et cetera. Why the veneers are more expensive because we have the lab do a very high level of restoration to get the aesthetic finesse. And that makes them more expensive than posterior teeth. I didn't do any of that with Phil. And so the question became, what do we do now? The hygienist actually was brilliant. She said, you know, call him back immediately and suggest that you want him to come in for an exam and some photos just to make sure everything's fine and to get some records before he goes to the other dentist, and don't charge him. So I did. I called him back immediately and I said, you know, Phil, before you go to the other dentist, I'd really appreciate it if you'd come in let me redo an exam, get a few photos, get some records, and I won't charge you for any of it. And he agreed. So he came back. I did the exam, I took photos, and then I showed him the value creation piece. Phil, I know you're going to this other dentist for the veneers, but I want to talk to you about the fact that on anterior teeth, you got to figure out what size you want them, what shade you want them, what shape you want. And these are the steps I go through to do that. Wax up, provisional, high-end lab work, etc. I said, so when you go to this new dentist, you might want to make sure that they have some steps in the process to assure you're going to like what the outcome is. So I showed him the whole presentation. Literally took 5 minutes. At the end of it, he turned to me and he said, okay, now I know why you're doing my veneers. And so I show you Phil as an example of don't get complacent and think that how long somebody's been with you is an example of how much they trust you or how loyal they are to you. We still have to treat people really well, but we still have to communicate with them and help them understand the value of what we do. Without creating that value, perceived value to them, we're just another dentist. They could go get the same thing at any office. And so to me, Phil was a real eye-opener for me because I never thought that I would experience that kind of pain from a patient I'd been around for so long. But it was a really good learning lesson for me and hopefully for you as well.
So I think what's super interesting about that is we did a lot of research when we built the original patient education product that we have. So we hired a medical research firm. We went out to all these adults. And again, there's a white paper if you want to read all about what went into it and the findings. But I got the opportunity to go and actually witness the 2 focus groups that we did. I sat behind the 2-way mirror, which is kind of creepy. But what was interesting is in both those groups, I witnessed the same experience. So in both groups, there was a patient who talked about, I'd been with my dentist for 5 years. I really thought they were good. And then I came in at one appointment and all of a sudden they found X. And again, what I hear in both of those statements is the dentist, one, assumed there was trust because of time in practice. And then 2, my guess is they were working from a scarcity model, right? So you showed the one tooth you thought they were going to treat until all of a sudden there were issues. And in both of those cases, the patients described how surprised they were. They didn't understand how this could happen in between 2 appointments. And, you know, there was this distrust that was created. And so what was really interesting in both those cases, they went and got a second opinion. And they talked about how, you know, they really looked thoroughly through everything. They said, yeah, those problems are there, but these 2 maybe we can wait on a little bit and these we can't. And what happened was both those patients went forward, eventually getting all the treatment that was originally recommended from the person who took the time. So even though they had been in these practices 5 and 6 years, you know, we saw the same thing. So I think it speaks to, we saw it in the research. And I think that's really interesting, kind of as you sort of verifies everything that you had talked about in our own research. So I think the thing that's really important here is, you know, we've just touched on some of these ideas and some of the research that we found. So I know a lot of you who are on this are members and, you know, members of the Spear community and are doing other things. So I want to make sure you know where you can go to get a lot deeper on this. So if you're on our online platform, you know, great place to go. We have a curriculum. It's a whole office curriculum that helps the whole office, because you talked about it's important to have the team on the same page. And so our whole office curriculum is designed to do that, to walk your team through in a time period all of these ideas. And so I would start with the Spear Online foundational curriculum. We have a specific pathway, which is more a didactic experience just for the doctor that walks through a lot of the research that we talked about. So it's based on the book that we did. And, you know, it's a great learning if you want to get real deep on this. And then the thing I would recommend is we have these facilitated team meetings. And if you're not doing these, please do. We're using them with all of our consulting clients, and they're pretty powerful. And it's a 10-minute presentation from Dr. Spear, one of our other resident faculty, and then it's a discussion guide for you to be able to talk your practice through all of this stuff so that you can be sure you have that cohesive experience within the practice. And then and if you are not a member and you want to see some of this stuff, if you go to this page that's right here, there's actually an interactive map of the practice that has a lot of the content on it. So you can see it for yourself. You can see a couple of the white papers that I talked about there to just experience. If you want to go deeper, there's a form you can fill out to talk to one of our advisors who will walk you through in depth everything, but you'll get a really great taste there. And then the last two things is I think, you talked about these two seminars specifically would be a great place for people to start out. You want to talk a little bit more about why?
Yeah, what we didn't have a chance to go into in this hour is what the concept of what we call filtering and the art of treatment planning and case acceptance. The first morning, we go through a lot of conversations about the concept of aligning the experiences you create with the expectations of the patient. And I won't go through it in detail here, but I'll just give you a simple example of filtering. 2001, my physician wanted me to go see a dermatologist because of a spot on my back. And so I'd never been to a dermatologist. So I called the office and the dermatologist receptionist said, well, how would you like to be seen? And I go, well, I don't know. What are my choices? And they said, well, we offer 2 new patient experiences. We offer a short consultation where we'll look at only the spot that concerns you and we'll give you our opinion. Or we offer, and that's about 15 or 20 minutes, or we offer a full body dermatologic exam, including photographs of any irregular spots so we can follow them over time. And that would take about an hour and 15 minutes. Which would you prefer? And for me, it was like, well, I want the whole body thing if I'm going to do this. Well, what that receptionist did is they filtered. And the way you really clean up a lot of communication issues with patients is you use filtering. So the treatment planning and case acceptance seminar, we go through a lot of filtering conversations for your receptionist to help you identify who wants a consultation, who wants to hear everything, who doesn't want to hear everything. And what it does is it sets people up, if you will, the processing part. It sets people up to hear your message differently. And then the worn dentition really, I think if you looked at most dental practices, tooth wear cases are an obstacle because dentists are fearful. And so you have a lot of patients in your practice who would really benefit from treatment, and they don't need to be complex full rehabs at all. A lot of wear cases can be treated with composite. A lot of wear cases can be treated with some ortho and composite. And so the worn dentition becomes a gateway to opening up how you see these cases that you don't really know what to do with. And you can discover that, in fact, in your practice, you may have 50 or 100 patients that when you realize that they can be treated relatively predictably and you can find a way to help do it with composite instead of extremely expensive reconstruction, suddenly you have patients that aren't getting treatment that you can really help. So those 2 seminars are really, I think they fit what our message is about patient communication really well.
So treating the worn dentition gives you would say, some of the skills or the know-how to treat some of those patients, and then you can have more of these conversations, and then art of treatment planning is going to go a lot deeper into what we said, plus go through the systematic treatment planning.
Correct.
Okay. So one last thing then, we only have one art of treatment planning left. It's coming up here in Seattle. We do still have some seats available. So if you can make it, it's our last one for this year. It's the last opportunity to